Good morning, everybody. It's great to be here to talk about my my PhD research. So thanks very much for having me. And I'm really pleased to be feeding back to UCLH about what I did in my study, and hoping that people will find it kind of interesting and relevant. It took quite a while. So yeah, I hope you find it interesting, and I'm hoping that we'll have lots of time to talk about what I found. It would be really great to hear people's opinions on it, and to get some feedback on if you think it could be useful and might be relevant to other tumour groups. So I'm just going to share my screen and just make sure that I've got my study up. Hang on a sec. Just bear with me a second while I get all this set up. Okay, is that okay? Everybody see that? Obviously I can't hear you, but I'm hoping that's okay. If not, then do let me know. Okay, so just a little bit about my background, first of all, for people that don't know me. I was at UCLH for 15 years, working as a cancer nurse in a variety of roles. I spent a lot of my time in the inpatient chemotherapy team, but I also did a stint in daycare and on the inpatient wards. And then most recently, I worked as a project lead with Lolita in a Macmillan funded role, working on the project implementing stratified follow-up for people with cancer. So I was lucky enough to, and I do genuinely feel very lucky about this, that I had my PhD funded, and I did my PhD at King's College London. And the basis for my PhD really was about the fact that we had a lot of discussions, as I'm sure many of you do now, about the pros and cons of giving treatment to people with advanced high-grade glioma, but also with various other advanced cancers. And I'm sure, again, there still are discussions around the importance of quality of life versus extension of survival. And these discussions really led me to do a pilot study prior to my PhD, looking at the impact on quality of life for people with brain tumours of entering a new drug trial.
Katie, sorry, if I can just stop you for a second. We have issues with the presentation. We cannot see it.
Can't you? Okay, that's strange. It's coming up on my screen. Hang on a sec. Let me try again.
Excellent.
Oh, hang on, I've gone too far now. Is that, can you see that?
Yes.
Okay, and you can hear me?
Yes, brilliant.
Okay, good. Okay, I hadn't moved off the title page, so that's fine, but thank you for letting me know. So yeah, this pilot study prior to the PhD was really, as I say, looking at the impact on quality of life of entering a clinical trial involving new anti-cancer drugs. And the findings were really positive and valuable, regardless of the drugs they were having. There was significant value to be gained from people going on to a trial in terms of the benefits they got, involving feelings of hope, feelings of optimism, and also the therapeutic relationship that they got with the professionals involved in the trial. So there was clearly a lot of benefits to their quality of life, as an aside to the drug, of going on to a trial anyway. So this really led to my PhD, which involved me wanting to find out more about the perceptions and experiences of people with high-grade glioma in terms of the impact on their well-being. And I'm going to briefly talk about what I did and how I did it, but I'm not going to spend very much time on that. I mainly would like to show people the findings, and I'm hoping that we'll have some time to discuss those at the end to really find out whether you think they make sense, and that they're relevant, and if they could be useful in practice or to other tumour groups, because doing a PhD can be a fairly lonely business apart from being with your supervisors and your doing your viva. So it'd be great to discuss it a bit more with people. So just a quick summary of what I did and how I did it. So this was a qualitative study because really it was about finding out how people felt and experienced things. So the specific methodology that I used was hermeneutical phenomenology, which basically in everyday language means just trying to find out more about the lived experience of people involved in the study, and then trying to interpret it and explore it to find out a bit more meaning about their experiences, and to try and find out a bit more why people feel and behave as they do, I suppose. So I did 27 interviews with 15 patients, some of whom had their carers there, some didn't. We gave them the option to have carers there. And where the carers were there, they were involved in the discussions, and these were included in the findings as well. So I did it over a period of 2 years, but the interviews really were done shortly after surgery, when the kind of the shock of diagnosis and the impact of the surgery itself was still very much in people's minds. And then I interviewed them again following the completion of their adjuvant chemotherapy and radiotherapy. So these interviews were all then transcribed with a professional transcription company, and they were all stored on NVivo 10 software. All the data was on NVivo 10, which was really useful software for me to use for analysis of the data. And I used a process called the hermeneutic circle for analyzing all the data, which was basically about reading and rereading the data, looking for key statements and collating themes, and then reflecting on these in terms of the context of the study and the background of people's lives. So I did kind of do summaries of their lives and their kind of cancer experiences as well. And then finally, this kind of resulted in a summary of my kind of first level basic themes. I also did some longitudinal analysis of the data. So what was really key to me was finding out how people's well-being changed throughout their disease trajectory. So I wanted to see what changes there were and what was important to them at different stages, and whether this did change. So I did the analysis within each case throughout the disease trajectory, and then also kind of across different participants at each stage as well. So it was quite a lot of analysis, and it was quite time consuming, but I think that ultimately it led to some really interesting data about how things change, and that was new evidence really, and new knowledge for this group of people that hadn't been looked at before in the literature. And a final note on methodology was a bit of a discussion around the use of the terms quality of life or subjective well-being. So when I started this a long time ago, there wasn't really much use of the term well-being, and that has obviously changed dramatically now, and it's a term that's used regularly in kind of health and political agendas, and the trends in the terms we used has changed a lot. But it was important to me that this was about subjective well-being, which was really more about people's life satisfaction, their kind of sense of self-worth, their degree of happiness and contentment, and all these things that were key to their subjective well-being, rather than more external factors like kind of environment and housing and finances, which obviously can have an impact but weren't important for this study. And also I wanted it to not really be about health status. Obviously these people all had significant health issues, but I wanted to look more at how well-being could be maintained regardless of what their health status was. So I did a concept analysis of subjective well-being, and to be honest, it was important for my PhD, but when I talked to patients, they obviously didn't know the kind of fine detailed difference or weren't bothered by it. They talked about quality of life, well-being, day-to-day life. They used a variety of terms, but to me, subjective well-being was the important part. So this screen I mean, I'm not very good at diagrams, so I'm sorry if it looks a bit busy. But this screen really shows my first level themes. So I came up with 20 themes that covered what people talked to about and mentioned were important in terms of their well-being. And they kind of roughly fell into 4 categories. And you can see the ones where there is like a higher density of arrows were the ones that were really talked about the most. I'm going to put my pointer on so that I can highlight some. So one of the main things that came through to me was very much this one, the importance of normality. Sorry, look at that. That's a terrible circle, but at least you can see which one I'm looking at. So people talked about normality a lot throughout this. And for most people, I would say, it wasn't true for everybody, but for most people, normality really represented their well-being and was what they strived for. So it was about their family, their social life, their work, what they could do around the home. That was the most important thing to them. But these were, the arrows kind of represent which themes were closely linked, and there was a lot of crossover. This was another important one. So the impact on family role and relationships, again, was really key, as well as the kind of impact on their working lives and their social lives. So there was a lot of crossover there. And the other one that was mentioned the most, I'd say these 4 were the key, was probably unsurprisingly about the symptoms of the brain tumour. That one was an interesting one because I'm not sure if they talked about that the most because it was easy to talk about because they're very used to being asked about their symptoms, and also because I was very used to asking people about their symptoms. So it was quite a good way to start the conversation that everybody felt comfortable with. But obviously their symptoms are can be the most significant factor anyway. But it could have been a bit of both, perhaps. And later on in the discussions, there was a lot more talk about, you know, the impact on their life and their psychological well-being. So this was really, really the key part. This section here and this overarching theme was talked about a lot, particularly in the second interviews. I think once people felt a bit more comfortable having a conversation about it. So these were really a summary of the data, but I wanted to find out a bit more about how these fed into a definition of subjective well-being in a more meaningful way, rather than just offering a summary of what people had told me. So when I looked at the themes again, it became clear to me that there were kind of 3 red threads running through all these themes. So the 3 key things that seem to underlie everything for people in terms of their well-being were around maintaining hope, maintaining their sense of identity, and maintaining a degree of control. And when I reanalyzed all these themes, I found that those 3 key domains of well-being really seemed to cut through everything. And that really led to my model of subjective well-being. I'm just going to have some water. Have a look at that. So it'd be interesting maybe at the end to talk about what people think about these themes and whether it kind of reflects what they find in practice. So this model, again, probably not a great diagram. This is not my strong point at all, but hopefully it kind of will go through as I add more layers in, make a bit more sense about the kind of overarching findings. So I wanted to look at subjective well-being as it changed throughout the disease trajectory. So it was really from the point of diagnosis right through to disease progression. And these 3 domains of hope, sense of identity, and sense of control were kind of present and overlapped throughout their journey and throughout their conversations with me. I didn't collect any data in the later phases. I didn't collect data when people were at the palliative care phase. I only managed to do 1 interview with someone at the point of them having stable disease. So it can't really apply to those later stages. That would have been interesting, but unfortunately it wasn't possible. So I realized that a lot of these themes that I'd identified really manifested as threats to people's subjective well-being. So throughout their journey of having their diagnosis and treatment, they were constantly subjected to numerous threats to their well-being. I'm not going to read all those out, but these varied from the day-to-day things that they were facing, like the side effects of their treatment and the treatment schedule, and the symptoms of their brain tumour. But it also included things like having to face up to the fact that they had a terminal prognosis, the loss of normality that they faced on a day-to-day basis. And also when they had negative experiences of care, this could have an impact on their well-being as well. So there's some kind of lines that are they're obviously not a graphical representation, but it's just to really show that. So this sense of identity domain, just to talk about that briefly first, this was very vulnerable at the time of diagnosis and surgery. The shock of the diagnosis, of being diagnosed with something as well that could affect their personality and affect their cognitive function, really did threaten their sense of identity. The loss of independence they felt after surgery was also a significant factor for people, understandably, that meant they felt like a different person and was very damaging to their self-image. There was an improvement, and we'll notice a trend here, that at the end of the radiotherapy and chemotherapy phase, so they went through a period of having combined treatment and then on to just single agent chemotherapy. So when they finished their radiotherapy and chemotherapy treatment, there was a significant improvement in their well-being because they suddenly had more time to spend on things that enhance their well-being. So their leisure activities, their time with family, their well-being did improve at that point. It was really about having more free time, and also the fact that their symptoms lessened enough to allow them to do a bit more, and they could feel this degree of normality returning. But then it did tail off, excuse me, after that point. So as their symptoms worsened and their disease progressed, obviously this was having more and more of an impact on their sense of identity and didn't really recover at that point. So the next domain of subjective well-being to me was really hope, and hope was such an interesting one that was really present throughout their disease and throughout the conversations, but it changed a lot, and they were redefining what hope meant to them throughout their time. So when they were having the intensive treatment, they hoped to have more time to spend on seeing their family and leisure activities and exercise, or just going out to the cinema, things like that, that they really hoped to be able to do at the end of their radiotherapy treatment. But the end of treatment also had a significant impact on their levels of hope, because this seemed to be the point where often people realized that they weren't going to return to the health that they had before their diagnosis, and really started to think more after that intensive treatment phase about their mortality. And obviously that had a significant impact on how they could hope for the future. But at that point also, there was some recovery in hope as they, as I mentioned, started to redefine what hope meant for them. So they would hope to get to see their child graduate from university, or they would hope to get to a social event that was planned, or they would hope to make changes to their working lives as well. Changes to working lives was really important. We'll talk about that a bit more shortly. And even towards the point where their disease was progressing significantly, they would be hoping for the life of their family after their death. So they would be hoping that their children could carry on to be happy and have a normal life. So hope was a really interesting one that changed a lot, but it was important to people all the way through. And that was something that we really need to support people with. And finally, a sense of control. So people having a sense of control over their lives and their treatment was the other thread that really ran through everything. Obviously, unsurprisingly, significantly affected at the point of diagnosis and through surgery and the initial intensive treatment. It was closely linked to hope and runs a very similar pathway, because I think it was very hard for people to feel hopeful when their lives fell out of control. So those two were kind of really closely linked. But at the end of treatment, I think as people had got more used to their treatment and they'd worked out ways to manage their day, they'd come up with ways to manage their symptoms. They did feel like they regained a sense of control over their lives, and being able to do things that helped themselves really, really had a positive impact on their well-being, because it helped them to feel that they kind of had regained a bit of this control. But end of treatment, again, was a real time of uncertainty for them. Obviously, there were feelings that I'm sure lots of people will see regularly, about feelings of abandonment at the end of treatment, and suddenly feeling like you're not having the contact that you're used to having, and also having more feelings about how their disease is going to progress, and uncertainty around what was going to happen next was a really significant factor. But there was kind of a bit of improvement, well, significant improvement at the end of radiotherapy and chemotherapy, and all the factors really. So that just showed that their well-being was much worse at the earlier stages, but when they had more time, it did improve quite a lot, because they had more time to do things that enhanced their well-being, basically. So I guess that all sounds quite negative in terms of talking about threats, and I know that threats is a negative language, but realistically, you know, they're going through an extremely traumatic experience. But there were some positive findings. So there was a lot of talk about strategies that people use to preserve well-being, or strategies that they had found helpful. So in terms of self-help strategies, some of these were very basic. So many people talked about how just making time to rest and allowing themselves to sleep was something that really helped their well-being. And interestingly, although a lot of people talked about feeling tired, they found if they had the time to rest, it wasn't something that was a major factor in their well-being if they could manage it themselves, compared to some of the other more kind of pressing emotional issues. And again, you know, this is only one group of patients. It doesn't necessarily reflect what others feel, but this was what people said to me. The other things that they felt useful to do for themselves was to maintain a positive outlook. They found very helpful when they found ways to manage their own symptoms. So when they could manage constipation through their own diet, they got a real boost from knowing that they were managing that themselves. And that seemed to be positive, both for obviously their physical feelings of constipation, but also in terms of their mental well-being, of feeling they were taking some control over their symptoms. But really the most important one was just retaining independence wherever they could, and normality. So even when they managed to cook a meal at home, do some jobs around the house, go shopping with their kids, those were things that really helped them. Positive experiences of care had the potential to really help to preserve people's well-being, and I'll talk about that in the next slide. People also found that reevaluating what was important to them was a really positive aspect of this process, and they talked about how it had made them reevaluate how they wanted to spend their life, and lots of people talked about that, and they saw that as a real positive opportunity. So where people hadn't enjoyed their work, they wanted to make a change. When people had enjoyed their work, they wanted to make sure they had time to focus on the bits they enjoyed. but also obviously, unsurprising, I suppose, about spending more time with family. There was a real kind of common thread of feeling like they'd spent too much time working, and they wanted to spend a bit more time doing what they enjoyed. And one real key thing, which I think is one of the main points that might be useful for people, was about the importance of goal setting. So this seemed to be a really positive way of people retaining their sense of well-being. These goals could be really varied. So some were really short-term goals, as I say, about getting to kind of an event. People who had been interested in exercise like to set themselves goals about getting back into cycling or doing more regular walks. So they were very individual, and they could be short or long term, but setting goals seemed to be incredibly valuable to people. Okay, so there's a lot of words on that slide. I'm just going to have a quick drink. So I guess these were kind of the takeaway messages for practice, which I'm going to go through by domain, and there's just kind of a few summary points for each one. But hope could really be threatened when people felt they'd had a lack of information and this hadn't been communicated well to them. And this was generally about when they felt uncertainty about their future. So when their prognosis hadn't been clearly communicated, they didn't know, and obviously they can't always know how long they had left to live. When they didn't know what their death was going to be like, and obviously people understood that they couldn't always get a clear answer on this, but they often felt that it wasn't really talked about, and that meant that it was difficult for them to plan for the future. But on a positive note, when people had confidence and trust in their clinical team, which these patients largely did, that really helped them to feel hopeful for the future, because it helped them to plan. It gave them confidence in their treatment plan, and it gave them a significant boost. And there was a considerable amount of reference to the value that people placed on the CNSs. So they found that their CNSs in particular, and other members of the clinical team, had the ability to really help them to preserve their hope, which just shows kind of how important that role is. They also felt that clinical teams that had a positive attitude, obviously they can't be giving them false hope, but having a positive attitude and kind of giving them something to hope for was very valuable, as was treating them as individuals. So obviously goal setting would be a very individual activity, you know, and I'm not going to patronize people by talking about that, but it depends what's important to people before their diagnosis and what they want to hope for the future. But really helping people find ways to feel hopeful was something that they found to be really beneficial. And I can't emphasize enough how much people talked about the value of having regular contact with someone who knew them, and someone they trusted, and someone they knew how to access. It was so valuable to their well-being. You know, it gave them a confidence to get on with their lives, which was really the key thing. But they talked about this a lot. So this study definitely supported the importance of someone having a kind of regular person that they can access. And again, these are people with high support needs, but it was really fundamental to them. And they, I mean, they all talked about how useful and valuable the CNSs had been and what a benefit they were. So sense of identity, I think, is probably something, I don't know, it wasn't something that I thought about in great deal when I was in clinical practice, about how important it was to really support people to retain their sense of identity. Again, this is so individual. So where exercise had been important to people before, where they did regular cycling or walking, or people that had been kind of triathletes, if they could be supported to carry on in those kind of events, that had a massive benefit to them. Diet, if it was important before, or if it kind of helped them to have a sense of control, then that was really useful too. And encouraging them to engage wherever they could in work and social events if they thought that would be useful was really a positive experience for them. And then one of the more specific findings, which I found really interesting, was about the mothers that I spoke to. And the people that were mums really talked a lot about their maternal role and how important this was to their sense of identity. It was fundamental for a lot of the mums that I spoke to. And again, it was really about supporting them to carry on with that role wherever they could. For some people, this was just about making sure they had time to spend with their children around their treatment schedule. For some of them, it was just about kind of making sure that they still just sat and felt that they could have a cuddle with their kids and watch TV. But for some of them, it was also about planning for their lives after death. So where they, you know, there is a tendency, I suppose, potentially in some parents to think very practically, and they wanted to have a practical plan about how they could talk to their children about what was going to happen and how they could plan for their lives to carry on after their death. And where those mothers felt like they could do this, that had a huge beneficial impact to them. So again, thinking about if your patient is a mother, that is fundamentally important to them and can be something that I think we could probably support them with a bit more. And then finally, the sense of control domain. I mean, this was really about people feeling like they were being treated as individuals. And again, that's nothing earth-shattering. I think most people know that where people feel like they're treated as individuals, that has a positive impact on their care. Where they felt they were just a number, this left them feeling powerless and like they didn't have a sense of control. They felt detached from the healthcare team, and it was really this kind of, it led to a feeling of loss of control. So it was really about kind of individualized communication. People wanted different levels of information at different points, and that was a very personal thing that, you know, some people wanted all the information at the start, others didn't, but they wanted to be involved in their treatment decisions rather than just feeling like they were a passive part of the process. So really making sure they felt involved in what was being decided about them and their lives helped them to have a sense of control, even though, you know, it might be that there is a standard treatment plan that's going to happen, but really making people feel involved was really important. And again, the goal setting came through as a really valuable tool as well, because it gave people a feeling that they were doing something for themselves, and it gave them something to hope for and focus on. Right, and this is my last slide, and then I'm hoping people can have a discussion about what you think about these, and you can give me some thoughts about anything else you think we should talk about. But one of the objectives of my PhD was to ask people about how they felt about the way we monitored their quality of life and the tools we use to assess their quality of life. And obviously there's a lot of those being used in practice, and I'm sure we're all very familiar with them. People didn't have a lot to say about the quality of life assessment tools. So I didn't get a lot of data on that, but the general information that people gave me was they found the questionnaires a very useful prompt for when they were at home to help them think about issues, but really they preferred them just to be used as a prompt for their discussions with someone that knew them and someone that they could trust. So they were really just more of a tool to enhance that discussion, but more important to them, there was often people saying, I just want the person that knows me, which was the CNS in this case, to check in with me and to have a conversation with me and ask me how I am. And if this tool helped that, then that was useful. But for them, and again, they're a specific group with a huge amount going on, and a significant burden on them. But really for them, it was more about that conversation with someone that knew them and that they trusted regularly that was massively beneficial. So I think just, you know, bearing that in mind and remembering the value of this personal relationship with the key worker, and knowing that these tools obviously have their use, but from a patient's perspective, they really put the most value on that conversation with someone who they knew and that they could trust. So yeah, that's my final point really on that. And I just wondered if people had any thoughts on it. I suppose might hand back over to Guy if he's there, and maybe have a bit of a discussion about it.
Hi, Katie.
Hi.
Can you hear me? Yes, I am there, and I wanted to thank you for this very thought-provoking presentation, first and foremost. We are now can open the floor for any kind of questions, so just please raise your hand or pop into the chat. If it's okay, I would like to have the first one. So you talked about the trusting relationship, and I guess what I'm curious about, did the patient discuss what were the challenges or what facilitated what they refer to as a trusting relationship with the clinical teams?
I think it was mainly someone that they got to know. So it was someone that they saw regularly, and that kind of phoned them regularly. I mean, this was there were obviously specific CNSs working with this group of people, but it was that regular contact, but also the people, they knew that they were knowledgeable about the treatment plan and that they could ask questions that they would get an answer to. But it was really that familiarity that led to the trust, I think.
And I guess then the question then, how can we, in practice, in clinical practice, how can we guarantee that? How can we create that sort of familiarity?
Yeah, well, for them, it was about the fact that they were in the early stages seeing people regularly in clinic because they were coming in for regular treatment. And they did talk about the fact that when they weren't coming in so regularly, that they noticed that support kind of diminished, and they would have appreciated, you know, I mean, I'm not saying this is realistic, but they would have appreciated more regular phone calls once they weren't coming in as often, just to maintain that level of contact. But it was yeah, having the key person in a small team. And I think it's also about the fact that this is not for every cancer patient. These were people who needed a high level of support. So I suppose in terms of resources and kind of allocation of resources, it's about prioritizing where the need is greatest. But regular contact was the key.
Thank you.
How you manage that in clinical practice, I guess, varies from team to team, and the person that does it will vary from team to team. But certainly the patients in this group felt that was being done really successfully.
Thank you. So while I think people are coming up with questions, if I can have just one more, because you've mentioned goal setting, and I think that was a very interesting point for me, because I think we know that goal setting is helpful, but I guess what, from their experience, from what you've researched, when is the time to actually begin to have this discussion about other goal setting or other aspects of life? When did the patients feel it was most appropriate or most effective to do that?
Well, again, it was so varied. And what the kind of goals that people wanted to set varied. But I think at the early stages, when I spoke to them, they were generally just starting their adjuvant treatment, and they had a huge amount of things to think about and things to process at that point. And really at those stages, they did want something to aim for, but it would be more about having more time to do things once that treatment had finished. But it could also be about setting a plan around kind of having a treatment schedule clear in their heads and, you know, giving them a clear plan. So I think that it would be very much led by the patient and their carer, and it might be something that they mention that's a small thing that they hope for, that you might be able to help them set a kind of very small and achievable goal at the start, but also kind of planning ahead to have something when they did have more time after treatment to look forward to after treatment. But it was so varied in terms of what people wanted to do, which I think was the real key. You know, if you'd have gone to some people to talk about exercise, it would have been the last thing they wanted to talk about. But even things like saying, you know, after radiotherapy, are there any family events that you're looking forward to, or a trip to the cinema, or you know, people often came forward with the things they wanted to set the goals for. And I think that is probably a better way of doing it, potentially. But it probably needs a bit more research, to be honest. I mean, this was only kind of first level research, and I'm sure it would be very interesting to look into it a bit more about what people thought about goal setting and the value of it.
Hi there, it's Fiona. Can you hear me, Katie?
Hi.
Hello.
Hello.
I think it's really interesting that you've highlighted quite a lot the value of the CNS and having that key person that knows the patient. And I just think increasingly, it's not. I think there's reasons why that can't happen. Obviously, with short staffing and people filling in and whatever, but I think it's just not always valued of that huge impact when someone turns up at clinic. And like quite often I have patients talking to me, and then they went in and it's just a doctor that's never known them. Oh, but I've got your notes here, and if you go over the issues with me again, and they're so disheartened.
Oh, it was a really bad experience.
Yeah, that they've been waiting for this appointment, and then they've got someone that doesn't know them. And I think even in my team, there's quite an emphasis on, oh, well, it's teamwork. It doesn't always have to be the same person, just hand over.
Yeah.
And I just don't think it's appreciated how much is lost by that way of thinking for the patient.
Yeah, definitely.
And that we lose out as professionals as well, because the satisfaction in your work comes from getting to know the patient.
Massively,
when you're just filling in and it's a bit more conveyor belty, it doesn't feel as satisfying. So anyway, I just think that's really important.
It was, and I know it's a permanent, it's an ongoing issue about how you kind of measure that value, but it was certainly talked about repeatedly, as exactly what you were saying. It's that one person, and there's nothing more disheartening than them coming to an appointment and then having to go over the same story again.
Yeah, definitely. Anyway, it was very interesting. Thank you, Katie.
Nice to speak to you.
And you.
Yeah, so that Anne Lansley raised her hand.
Hi, Katie.
Hi.
Yeah, really enjoyed your presentation.
Thank you.
It's fascinating. I think that you asked the patients what they thought the role of the quality of life instrument assessment was, because I'm sure you're aware of there's a great interest in using quality of life instruments to aid decision making, particularly difficult decisions over treatment. And it was really fascinating from your study. Actually, the patients didn't perceive them in any way as useful in that respect.
No, they couldn't.
Yeah.
They had very little to say on it. It was hard to get much data about it at all. They just saw it as something that was a part of the treatment, but really its value was as a prompt to a conversation.
Yes, yeah. I mean, what do you think needs to happen? You know, because I mean, I believe they do have potential in you know, addressing these very difficult treatment decisions when the benefit of the treatment is not borne out in well-being and quality of life. And what do you think might happen? I mean, your research is quite powerful in this respect. I mean, it's...
Well, I suppose, I mean, it's different in terms of whether you're using it to make decisions about treatment or as a tool to kind of support. And I mean, it's just not a supportive tool to them, I suppose, would be the key. If it's an assessment tool that you're using to inform decision making, then I suppose that's a different thing in terms of keeping a track of how they're doing. But from the patient's perspective, where they really are valuing the support, it was the conversation with someone that knew them. And again, I suppose it depends, you know, you've got some people with cancer who have very different experiences of that just don't need that level of conversation and support in the same way. And I suppose it's about prioritizing where that support goes. But obviously there is a lot of value in using it as a monitoring tool, but maybe less so from the patient's perspective in terms of a supportive tool.
Interesting. Yeah, thank you.
Thank you.
We have a question from the chat from Sam asking, have you got any tips around how to have discussions with patients and the family about death, how long they may have left, and guiding them through getting their affairs in order?
I don't really have any tips about that. And I think probably the Macmillan Support and Information Service would be the best people to help with that. I mean, my conversations were, I did find that after, it was in the second interview where people felt more able to discuss that. But I think it's a really important issue that I didn't feel, to be honest, I didn't feel confident doing when I was working on the wards. And I'm not sure, I think probably, and maybe it's different now, but that it's something that we could all do to get a bit better at, and something that needs, a bit more of a focus. But again, it was when, it's difficult in practice, I think, because it was when people felt they had time and you had the time to listen, that they felt comfortable in opening up about it. But I think I would defer to the experts in that one, and just say that this work highlights how important it is to have a focus on it.
Excellent. Well, I think this will be an excellent ending point. Katie, as you can see probably from the chat, people are expressing their gratitude for being able to hear your presentation today and saying how excellent it was. Yes.
Thank you everyone for coming. I really appreciate people coming to listen. Thank you.
So please do read it because there's some lovely comments over there. If I can now express my thanks for everyone for attending, I'm going to put in the chat our Survey Monkey Link for evaluation form. We would highly appreciate any kind of feedback, so please do complete it. And let me just share my screen for one final time. Yes, so if you want to be added to our circulation list, please contact Lalita Carballo at this address. There's the Survey Monkey. We will send out certificate of attendance. You can find the YouTube recording in the following link, and all of the information you can find on the Eventbrite page. So please do follow it, and then we'll also have information about our next presentation in October by Professor Nick Halbert-Williams. Thank you all for coming, and looking forward to seeing you in the next one.
Thanks, everyone. Bye.
Thanks very much.